To recognize the consequences of CKD on bone, it's important to understand what happens in healthy bones. Osteoblasts and osteoclasts are functionally coupled, and opposing yet balanced activity ensures the appropriate level of bone turnover, mineralization, and volume, or TMV, to maintain normal bone quality and quantity and to respond to environmental stress. In CKD patients, this balance becomes deranged, resulting in a spectrum of disorders. These disorders can be illustrated using the new TMV classification system proposed by KDIGO. This system helps us communicate using consistent medical terminology and may help define pathophysiology and guide therapy. The gold standard for the diagnosis of renal osteodystrophy, a bone biopsy, is often not practical. Therefore, despite its limitations, PTH measurement is the best test for evaluating bone disease. However, measurement of additional bone markers, such as alkaline phosphatase or bone-specific alkaline phosphatase, or BALP, may add value in certain cases. Studies have demonstrated a correlation between elevated alkaline phosphatase, PTH, and histological alterations indicative of high-turnover bone disease. Low BALP levels have been associated with adynamic bone disease. Trending of these biochemical measurements may be used to monitor the type and progression of disease. By the time they initiate dialysis, most of our patients exhibit mild hyperparathyroidism as measured by an elevated PTH. Elevated PTH is associated with disorders characterized by abnormal and increased bone turnover. High turnover disease, observed first as mild hyperparathyroid-associated bone disease and progressing to osteitis fibrosa, is associated with an increased risk in both osteoblast and osteoclast activity, resulting in an increase in bone formation, resorption, and endosteal fibrosis. Osteoid area and volume can increase as osteoid seams thicken due to overproduction of collagen by osteoblasts. Frequently, this collagen is disordered, resulting in an abnormal or woven osteoid. At the other end of the renal osteodystrophy spectrum is low bone turnover disease associated with relatively low PTH levels. This disorder is associated with diabetes, age, nutritional status, and oversuppression of PTH. Osteomalacia and adynamic bone disease are low turnover bone disorders. Osteomalacia is characterized by an accumulation of unmineralized bone, or osteoid, and inhibition of collagen deposition. Wide lamellar osteoid seams are observed, osteoblast and osteoclast number and activity are decreased, and there is an absence of endosteal fibrosis. Osteomalacia was common, but has declined greatly due to the reduction in aluminum toxicity. In contrast, adynamic bone disease is characterized by very few or absent osteoid seams. It is a defect of bone formation and mineralization as both osteoclast and osteoblast function are decreased. Mixed uremic osteodystrophy displays features of both high and low turnover in differing proportions for patient to patient.